This is an abdominal interesting case study on Ileus by Jessica Klein. What is Ileus? Ileus, by definition, is a painful obstruction of the ileum or other part of the intestine. It can be either mechanical or paralytic, which is also known as functional. For sonographers, this is important because when there's ileus, peristalsis does not occur in the bowel, and we often use peristalsis to differentiate masses from bowel. The etiology of this, mechanical ileus, can be caused by impacted feces, hernias, tumors, adhesions, and foreign bodies. Where paralytic ileus can be caused by narcotics, decreased blood supply, bacteria or infection, abdominal surgery, appendicitis, kidney disease, or lung disease. Symptoms. You can have abdominal distension, constipation, you may be unable to pass gas, you may have diarrhea, vomiting, or breath odor. It's usually diagnosed by an abdominal CT scan, an abdominal x-ray, barium enema, or upper GI and small bowel series. Now here's my patient history. This patient had a lot of history before coming to even see us, so I'm going to go through it day by day. On February 3rd, 2020, we had a patient present as a 37-year-old female. She presented at the hospital with right lower quadrant pain and vomiting. A CT was ordered with contrast. There was no evidence of large or small bowel obstruction. Dilated appendix with moderate surrounding inflammatory stranding compatible with acute appendicitis. Trace pelvic free fluid, and a surgical consultation was advised. These are the images obtained in that CT scan. You can see that the bright white areas in the abdomen indicate the appendicitis. From February 4th to the 5th, the patient has an appendectomy. The patient complains of unspecified abdominal pain, and the patient complains of vomiting. On the 6th, the next day, the patient has an abdominal obstruction series x-ray. Multiple gas-filled loops of small bowel are measured up to 5 centimeters. She has a small amount of gas in the large bowel, a small amount of free air. This is considered to be more typical of a bowel obstruction, but could also represent postoperative ileus, and air beneath the right hemidiaphragm, which is considered normal because she's post-op. The patient also has a chest PICC line placed, and during this exam it was noted that she had persistent dilated small loops of bowel, and they questioned an obstruction. On February 7th, the next day, the patient still has continued abdominal pain, so they undergo another abdomen obstruction series x-ray. Multiple air fluid levels in the small bowel consistent with post-operative ileus are seen, and a small amount of free air under the hemidiaphragm that is still consistent with her recent surgery. On the 9th, the abdominal pain is still there, and now she's developed a fever. So the patient receives a pelvic CT without contrast. It's limited due to the lack of contrast, but they notice that the patient has a hiatal hernia. The distal small bowel is markedly distended and fluid-filled. The cecum, ascending colon, and proximal transverse colon are distended and fluid-filled, most likely representing postoperative ileus. There's a 2.4 by 2.2 by 1.7 centimeter fluid collection adjacent to the staple line that they're thinking is a possible postoperative abscess. And this time they notice a 5.9 by 5.2 by 6.7 centimeter ill-defined, low-density, soft tissue mass that's consistent with complex fluid. It's a new finding that was not seen on a prior study and displaces the uterus anterior to the left and the rectum posterior to the right. It's a possible hemorrhagic cyst or postoperative abscess. Here you can see the pelvic mass just above the uterus on this image. You can see how it pushes the uterus over too. Now, all of this happened before we even saw the patient. So now at this point, the patient shows up to us and we have reviewed all the history I just went over. So for us, she presented as a 37-year-old female with a post-operative infection, a complex fluid collection in her pelvis, a fever, and abdominal pain. For the ultrasound procedure, we performed a transabdominal pelvic ultrasound. We took images in both the sagittal and the transverse planes. There were no transvaginal images obtained due to the exam originally being requested as a right upper quadrant. After we talked to the radiologist, we realized that transvaginal images were not necessary. We got enough transabdominally, and she was in a lot of pain. We also included volumetric sweeps and still images, and the patient was in a supine position during this exam. The ultrasound equipment we used was a GE Logic E9 ultrasound machine, a curvilinear transducer. We did take some images with the linear transducer just to see if it would be better, but it wasn't, so we didn't include them. We also used ultrasound gel and towels. In the radiologist report, they noticed that the uterus is anteverted, measuring 8.4 by 3.4 by 4 centimeters. The contour and echo texture appear normal, and the cervix showed no suspicious abnormalities. The endometrium had a normal caliber of 7 millimeters, an IUD is in place, and it was homogeneous and normal in appearance. The right ovary measured 3.4 by 2.6 by 2.7 centimeters. There were no suspicious right ovarian abnormalities, and Doppler flow was within normal limits. The left ovary measured 3 by 1.9 by 2.1 centimeters with no suspicious left ovarian abnormalities, and the Doppler flow was within normal limits. They also noted that there is a complex fluid collection within the pelvis on the right side, posterior to the uterus, measuring 7 centimeters by 5 centimeters by 6.5 centimeters, and they said that this most likely represents a postoperative fluid collection. The additional rounded area is evaluated by our technologist in the lower left quadrant in the anterior aspect of the abdomen. There is no correlating soft tissue abnormality in the area on a CT. This likely represents a dilated small loop of bowel, which we later come to find out which is what was caused by the ileus. It's what we were seeing that we thought was a mass, but it was actually a small loop of bowel that was looking this way due to the ileus. So here's a picture of what we saw. I can say that I was there for this scan, and we stayed on this spot for quite a while. We took many cine clips, and we looked for peristalsis, and it just didn't happen, which is why we assumed that there was a mass. So I found this very interesting because the students were always told that if we're not sure if something is bowel, we should stay on it, watch it, leave and come back. If there's no peristalsis, then it's probably not bowel. But in this case, that wasn't the case. That wasn't the fact. It was, in fact, bowel that was simply not peristalsing due to ileus, which is what I found interesting. In this image, it's the same image as before, but the part that I circled there is where the radiologist actually explained to me that he decided that this was bowel and wasn't a mass because he was able to blow it up and show the different layers of the bowel and exactly how he determined that this was ileus and was not a mass. Here you can see another view of the same part of bowel. You can see here that we measured it because we thought it was a mass. This is a little more medial. We saw it in multiple places, which was confusing us until we figured out what it was. This, you can see, is that collection of fluid. You can see that it has some septations, and it's just got some low-level echoes, and it looks a little dirty. Overall, it just didn't present as a normal cystic structure. That's, what gave us an idea that it was something more. And, of course, we measured it. Now, for the diagnosis for this patient, she had the appendicitis, which was diagnosed before she saw us, and then the postoperative ileus and the postoperative abscess. The differential diagnoses for these things, for the appendicitis, there really wasn't one. It was pretty obvious. For the postoperative ileus, they thought it could be an obstruction, and for the postoperative abscess, they thought it might be a hemorrhagic cyst. So for image evaluation, I would say perhaps decrease the depth, lower the focus, and do your best to prevent drop-off. But I was there for this, and she was in a lot of pain, so I think that we did the best we could. The other imaging modalities used were a CT with contrast, a CT without contrast, and X-ray. The patient care plan, as of February 10th, which was the day after we saw her, the patient underwent a CT-guided percutaneous drainage. 30 milliliters of serous angineous fluid was aspirated. It was sent to the lab for culture, and successful pelvic drain was placed. As of February 11th, the patient was discharged. This patient wasn't from our area. She was actually here vacationing at one of our resorts, so we were unable to follow her any farther as she took the rest of her treatment at home. So here are a few of the sources I used for this project, and that concludes my presentation. Thank you.